Hello all, thank you for joining the CCIH virtual conference. Our discussion today is on health facilities readiness in humanitarian emergencies. We're going to wait just a couple more minutes while people join and then we'll get started. All right, so once again, thank you very much for joining. This is the CCIH virtual conference, and our discussion today will be on health facilities readiness in humanitarian emergencies. It's really a pleasure to welcome everybody to this webinar. My name is Dr. David Beversluis. I'm a health advisor working with Médecins Sans Frontières, or Doctors Without Borders. Welcome to this conference. As you know, CCIH has been doing the conference this year online, and it's really a pleasure to be part of that. Let me tell you just a little bit about CCIH. This is an organization that is an international network of approximately 115 Christian organizations and 15 secular partners, as well as a few hundred individual members. CCIH's mission is to promote health and wholeness from a Christian perspective and provides opportunities for capacity building, networking, sharing best practices, and advocacy. For me, CCIH is really an organization that has meant a lot to me over the years, and I'm really, as I said, thrilled to be part of this conference. Our sponsor this week is Health for All Nations. The mission of Health for All Nations is to engage the global Christian community in the exploration and application of biblical revelation, scientific evidence, and cumulative experience as they relate to health and wholeness, and to assist the global church in fulfilling its mandate to promote health and healing among the nations. We thank them especially for this, for their support this week. We also want to encourage you to share what you've learned on social media. You'll see on the slide CCIH and Health for All Nations Twitter names, as well as the CCIH 2020 hashtag on this slide. So feel free to post online and engage in social media in that way. Just would like also to explain the flow of this session. This will be a panel discussion without formal presentations. We'll start off with a few questions, but then we're really looking forward to hearing from all of you as well. And we encourage your questions. This should be interactive and lively conversation. Please type your questions into the chat at the side of the video on YouTube. In order to post a question, you do need to be signed into Google and have a YouTube channel, even if you don't have any of your own videos to share. Or if you prefer, you may email questions to webinar@ccih.org, and then we'll get to those as well. So that's webinar@ccih.org. This webinar is being recorded and will be posted on the CCIH YouTube channel in a conference playlist. And you'll be able to find links to the recordings on the CCIH webpage as well at www.ccih.org. So with that, I'd like to get started, and I'm going to first introduce myself briefly, and then our two distinguished panelists as well. I'm, as I said, Dr. David Beversluis. I'm a health advisor with MSF, or Médecins Sans Frontières, Doctors Without Borders. I've also recently worked as a assistant professor of clinical emergency medicine at the University of Southern California. Recent field visits with MSF have included working last year in DRC as a medical coordinator, working in Bangladesh, helping set up camps, the Rohingya camps in southern Bangladesh, and in 2018 working with MSF on the search and rescue ship, the Aquarius. We have two speakers today, and first we have Peter Yeboah. Peter is the executive director of the Christian Health Association of Ghana, which is the largest private, not-for-profit and non-state provider of health services in Ghana. Peter is also the chairman of the Africa Christian Health Associations Platform, or ACHAP, a member network representing over 41 Christian health associations and health network organizations throughout sub-Saharan Africa. Also joining us is Dr. Ann Peterson. Dr. Ann Peterson is the senior vice president of global programs at Americares. She began as a missionary in Kenya and Zimbabwe, consulted on neglected tropical diseases for the CDC and WHO, and then moved into policy and political positions, first as health commissioner for the state of Virginia, and then as assistant administrator for the Bureau for Global Health at USAID. So thank you to both of our speakers for joining us today. I'm going to start off with just a couple questions, and then we can open the discussion there for your questions as well. We really hope to hear from you. So again, please either write them in the chat box on the side or email to webinar@ccih.org. So today we're really hoping to focus in on what it means to be prepared in a health facility. And a lot of us are participating and running health facilities all around the world. We want to be as practical and grounded as we can to the realities that we face in the hospitals and at our project sites. So as you think about questions, think about that as well. What tools exist? What can health facilities and organizations do to prepare for emergencies, ranging anywhere from small mass casualty events to outbreaks, or as we're dealing with now, the large global pandemic of COVID-19. So of course, we'll come to that topic as well. Many of our health facilities are actively preparing for this wave, which is expected to hit. And so we'll deal with that as well. So with that, we'll turn to both you, Ann and Peter, and would like to open up a little bit the discussion. Maybe to start, if you could each give us a brief introduction of your organization and give some examples of what you see as emergency preparedness in your organizations. Maybe, Ann, we can start with you.
Sure, thank you. So Americares is a global health and disaster response organization. And when I think about the journey that the organization I've been part of, it mirrors where I was in my career. I began as a clinician and then said, whoa, we have to get on the front end of the immense health problems that I saw on the ground in Africa. And I moved into public health. And Americares as an organization began as a medicine and supply distribution organization, a disaster response organization that got meds and supplies out there, and then realized, whoa, things are really bad. We need to get there on the front end. And so we really grew our response into a very robust preparedness. The organization also has really owned the space of the local health center, less so the classic sort of global health community. And so as we think about both response and preparedness, it has been very much focused at that primary care level, local health center. So we have tools, we have preparedness experts that can walk people through the different toolkits. And we have some personal ones, but probably the most important for this audience is we have both an all hazards preparedness toolkit. It goes through the things that many of you already know, probably already have put in place, but in a very checklist, complete manner, so you don't forget. Do you know the names and numbers of your staff? Do you know your high-risk populations? Do you know how to reach them? And lays out a template that you can fill in all of your contacts, your people, your time frames. And then we have teams that will actually help a clinic go through that, develop their plan, practice their plan, because we found that really makes a huge difference as well. So lots more I could say, but hopefully we'll do that in the questions.
Yeah, absolutely. Thank you. Thank you for that. And yeah, definitely more to say on all of that. So we'll come back around, but why don't we jump to you, Peter, and tell us a little bit about your organization and about the ways that you view emergency preparedness in both CHAG and HAP.
Yes, thank you very much, and good afternoon to colleague panelists and all virtual listeners, afar and near. It is very much exciting. I am the Executive Director of the Christian Health Association of Ghana, CHAG, that is in Ghana, and also as part of HAP. CHAG, as the introduction indicated, is the largest non-state actor in health, providing about 40% healthcare in Ghana. And we have long been in the system, many, many years, even before the Ministry of Health was born. Remember, the early missionaries came in with this holistic development concept, education, health, and the church spirituality. So we have been involved, or we have been the frontline actors when it comes to the holistic package of health services: preventive, promotive, rehabilitative, palliative, and all the other streams of healthcare. When CHAG heard of, or when Ghana heard of this whole COVID, we saw it as remote and distant from us. How could such, a disease from Wuhan travel all the way to the United States? So we felt it was remote. So we had no sense of emergency preparedness. But as the reality hit harder and started coming in, we had our index case, then we realized the need for a robust, quick COVID, readiness, preparedness, and response actions. So what did we do? We first had two paradigms. We realized first and foremost that primary healthcare facilities are the frontline agencies in managing this whole COVID, in these COVID response actions. Why do I say so? We realize that the most important resource in this whole COVID response is the healthcare professionals, very important. And when we listened to the nature of this whole COVID, that the spread, we saw that it was moving from personal to cluster to community. And we felt strongly that the best way at community containment, containing the community spread, is to ensure that the hospital environment is well prepared, because it's the hospital environment that will identify, test, trace, track, and also even refer patients and clients. So the first thing we did was, after realizing that COVID literacy was very low, people did not really had sense of risk apart from the fear. The first thing CHAG did was to set up a steering committee to look at issues of risk communication, case management, and coordination of all efforts. and see how can we then define what, cases are suspected, probable, confirmed, and how do we align it? How do we mobilize resources? How do we do so? Because remember, Ghana has never had any emergency, public health emergency of such magnitude and scale. So it was novel. It was really new experience. So we felt that one, we needed to ensure COVID literacy amongst healthcare staff, first and foremost, educate them very well. We needed to identify what resources may be needed, the PPEs, what we call it, and how do we at the same time also ensure continuity of routine services and the rest. And I'm happy to say that leadership was very important within CHAG. We realized that political leadership was necessary. CHAG being a frontline or an actor that has a special mission, had to assume leadership from the community level. And remember, most of our facilities are located in the rural areas that are quite neglected. And we also realize that the political response or government response has been city-centric, urban-centric, so much that the media attention was too much focused on the urban areas. So we provided leadership in mobilizing all our network in preparedness in terms of trade triaging, infection prevention and control, WASH compliance, and how to manage, case management and all the others. And then also looking at how we could mobilize resources to fight COVID. Apart from the competencies, which we see as resources, how do we ensure that we have the basic first line COVID commodities, not the high level PPEs, the nose mask, simple infection prevention control measures and the rest. And I'm happy to say that despite the high infectivity rate, CHAG facilities got quite prepared to respond to this whole pandemic. And so also from Ghana, HAP also had to really rise up and prepare in the larger continent, and to mobilize resources, connect with our partner to see how can we raise the alarm bell higher, how can we provide COVID as real. Remember, denial has been an issue, lack of preparedness, and no one foresaw COVID coming. So in a nutshell, COVID as it is, novel as it is, provided an opportunity for us to understand what it meant to appreciate clinical and public health emergencies, how to prepare, and how to profile essential materials and resources to respond to, disease of such magnitude and scale and such prominence. Probably I'll pause here and wait for more questions from the other panel.
Thank you, Peter. I actually have a really quick just follow-up question on that. You guys have been doing lots of work on all of this preparedness, as you just outlined. Have you seen facilities yet where there's really been a wave of COVID and uptick of respiratory type patients where that has kicked in and been affected?
Yes. In fact, we were able to negotiate with government and the Ministry of Health to designate some of our facilities as COVID treatment centers. And that enabled us to prepare, have the basic equipment and all the others. And then as I speak to you now, we are seeing a new wave of COVID infection, and the case management competencies have been very much useful. We are seeing some of our facilities recording COVID cases, and then some of our staff too have been infected. And I'm happy to announce that virtually all the confirmed cases or active cases we handled were successfully handled, and most of them have tested negative after 3 weeks of confinement, isolation, treatment. And what we are seeing though is a wave of new infection amongst the healthcare staff, even though we've not recorded any mortality, but it is yet a warning sign that probably much as we focus more on clients that will come to us, how about our healthcare workers and staff? How prepared are they? How do we preserve, protect them to respond to their original mandate of doing so? So certainly, cases keep coming. We are seeing exponential spike every day. It is also appointed to us for us to prepare very well, to get the necessary resources, the necessary training, the competencies to ensure that we prepare adequately, also including BPAP, CPAP, ventilators, and the rest that are necessary to handle advanced cases. Where it is beyond us, we'll naturally refer to higher levels. But so far, CHAG has been able to respond to others. And I believe that is the case in several HAP countries afar.
Great.
Over.
Well, thank you. Thank you. Maybe, Anne, I would ask something kind of similar. What is your experience with this so far with Americares and some of its partners, and maybe tying into the tool you already mentioned?
Great. So Americares works both in the US and across the world. And obviously, after China, the US was hit next. We both support small, free, and charitable clinics, which are the safety net space in the US, but we also have 4 of our own in Connecticut, right outside of New York City. So our own staff that are providing direct services in our Connecticut clinics were right front and center with the big surge in the New York metro area. So not only did we get to, with our own staff, use our template for preparedness, which began as an all-hazard preparedness template and model, and now has been modified specifically for COVID, which with much more attention to infectious disease, infection prevention, control, separation of patients. But we've been able to see how our preparedness plan has helped them be more successful in response. Unlike Peter's experience, we had a number of patients, because we take care of the poorest, even in the US, who had a lot of exposure to COVID. And we've had a number of positive cases, including 2 patients who have died. And one of the things we realized in our preparedness is that we hadn't defined what happens when we're a primary care site. We don't see really sick patients who die very frequently, and we didn't have grief counselors and referral mechanisms for some of those things. So that's now part of our preparedness, to actually think through all of the different areas. But we also work in Colombia for Venezuelan refugees, and in the urban slums of Mumbai in India. And we've been using our preparedness module to figure out how to keep our staff safe, which Peter talked about. How much and what kind of PPE could we be using? And the triage. Things like, who are our partners? How do we know how to get a hold of them? What are our supply chains that will be bringing in our needed medicines and supplies over time? So it's been really helpful. I just want to mention an example in a response from my time in Puerto Rico responding to Hurricane Maria. I was there within the first day, and it was incredibly dramatic to go down to the southern part of the island, which was very hard hit. And there was one health facility that was up and functioning within hours of when the hurricane hit. They had their doors open. They were seeing hundreds of patients. They had electricity because they made generators. They had a preparedness plan, which was in place, which was practiced. They'd gone through it before the hurricane hit, and they were functioning. And 2 miles away, one of the referral hospitals was closed down. So preparedness can make a huge difference. And Peter mentioned fear. There has been so much fear, almost fear driving the epidemic as well as everything else. What preparedness does for people, so on a personal level, but also for a health center, is it gives you back some of the control. It gives you something you can do to tamp down the fear, to have an active response so that you can go to work as a nurse or a doctor or an ancillary personnel and know that you're going to be protected in providing care for your patients. So it changes both the attitude and the functionality if you have gone through your preparedness.
Yeah, that's really great. And it's this aspect of control is, I think, something that I've seen as well, and it's really important because it allows you to maintain your capacity to continue to provide regular services, right? We're dealing with COVID, we're dealing with a huge pandemic that's straining systems all over the world. And whether it's that or whether it's 15 people from a bus accident rolling into your emergency department, having a plan set up ahead of time that allows you to kind of adapt and be flexible. Mass casualty plan for that latter example, or some other larger emergency preparedness thinking, really helps you maintain that level of control. How do you both of you see that issue for your programs? How do we, despite overwhelming emergency pressures and distraction from COVID, for example, how do we continue to really maintain our regular programming in our health facilities?
I'd be happy to start. This is probably the issue I'm most passionate about in the COVID response. We learned, or we should have known even prior, but during Ebola in West Africa, everyone was so afraid of Ebola and focused rightfully very hard on Ebola, knowing who had it, taking care of those patients, trying to protect the healthcare workers, that they stopped doing the primary care services. And if you look at the morbidity and mortality, both during Ebola and after, stopping those primary care services probably contributed to as many deaths as the illness itself. I think that's even going to be more true in COVID in places where they're stopping their primary care services. And COVID, thankfully, is less lethal than Ebola was. Again, a Puerto Rico example, I was in my hotel and a man walked in about a week and a half after the hurricane hit. He was holding his bottle of insulin. He says, "I don't feel well. Is there anybody here? I heard there were doctors. Can you do anything for me?" So right there, we tested his blood glucose and it was over 450. I mean, very dangerously high. And he was a potential fatality for not being able to access the health system. We saw the same thing again in West Africa, where a nurse who recovered from Ebola talked about her father dying with a hypertensive crisis while she was in the hospital for Ebola. So keeping the primary care services going during COVID, preparing now for how are you going to separate COVID patients from non-COVID patients so that we can prevent that excess mortality, be part of the preventing health harm. And I think that's probably the most important thing that primary care services can do, is keep their doors open, know who their patients are. We've moved to a lot of telemedicine, so I hope we could talk a little bit about how do you do that, not just in the US, but our India team is doing it through WhatsApp. Do you know your patients' WhatsApp numbers to be able to contact to them? Do you know the ones who have chronic diseases who need medicine or are fragile and elderly and need more constant care? So I think there's so much that we can do in this area, and really probably the biggest contribution to saving lives during this outbreak.
Yeah,
great. Peter, any other thoughts on that topic there?
Yes. I think, thank you very much. This is very interesting. We are realizing in Ghana and certainly in Africa, HR countries elsewhere, that the case fatality rate, attributable to COVID is extremely low. And in the case of Ghana, you find that at a time when we had about 4, COVID-related deaths, we had about 40, deaths related to CSM, cerebrospinal meningitis, in the upper part of Ghana, which had low, publicity. And we also saw that in the midst of the COVID, there was this suspension of essential services like, ANC by hospitals, and the fear that pregnant women may be infected. Now, the sum total of this whole thing is that the unintended effects of probably the overhyped COVID and the legitimate need to contain COVID is leading to low demand or utilization of essential services. So in a way, continuity of routine services is being affected. And the fear is that post-COVID or even during COVID, some of the non-COVID deaths or unintended deaths associated with this whole COVID containment might even be more. Immunization has suffered, is suffering. And then there's also the general fear, stigma associated with any hospital that records COVID cases, that this is probably a place where when you go, you may contract, maybe COVID infected. Healthcare workers are scared, they are fear. So we are looking at how do we, restore confidence, promote demand and utilization of routine services in our system. And then even also by this whole COVID, containment measures, people with underlying medical conditions, NCDs, who are highly susceptible, are not having their, their medicines are not visiting that place. So it is real, and I think the earlier we look at managing demand or promoting demand, maintaining routine essential services alongside COVID containment, probably we may experience something else beyond this whole COVID thing that we're experiencing out of either overhyping or whatever it is. And then we believe strongly that some innovative ways and means should be made to strengthen our health system, absorb the shocks, the buffers, the fear, the uncertainties that is coming, so that basic cases like malaria, upper respiratory tract infection, which were all very common, could be well taken care of. As we deal with COVID, I'm right on hand. Over.
Great, thank you. We're at the 30-minute mark now, and I have a couple more questions in reserve, but since we have an active audience, there's starting to be some questions coming in, so I thought maybe we could take one of those. There's a question here from David Scheiman of LifeNet International, and he asks, what are some of the other lessons learned from prior epidemics, Ebola being an example, and Anne, you already mentioned one example and lesson learned from Ebola. But are there other lessons learned either for fighting COVID-19? And then I'll also bring it back to our kind of topic here very concretely. For health facility readiness, are there examples that either of you have seen that we can pass to our audience around how to really focus on that issue? Go ahead, Anne.
Sure. I have probably two other lessons learned from Ebola to COVID. One is one of the clearest things. Peter just talked about how some of the symptoms overlap as well. And both COVID and Ebola, part of the problem in being able to separate the infected patients from non-infected patients was, is the fever Ebola or is it malaria? Is the respiratory symptoms, is that a flu or is it a cold or is it COVID? That's being able to separate so that you can take care of your COVID patient and separately take care of your non-COVID patient. I saw the testing and rapid testing being the most critical missing piece during the West Africa Ebola outbreak. And we have that tool now that is making a difference in current Ebola outbreaks. Testing's been pretty controversial around COVID. We didn't have one, we're starting to get them. They're sort of reliable, but they aren't yet very rapid. And so we are still being limited in our being able to screen, triage, and separate the patients. I think that's going to be absolutely critical to being able to successfully contain the epidemic and to protect the healthcare workers. The other one that and this will be perhaps a personal bias shared by this audience, in West Africa, we came in with an international response, a whole bunch of government agencies and WHO and the government, and it was not a very community-oriented response. I got there pretty late in the outbreak and found that few of those big policy decision makers were actually talking to the people. And so I went with World Vision as a consultant, and I partnered with a CDC epidemiologist friend, and we just talked to people in the slums of Freetown and Monrovia and said, what is it, why aren't you responding to the messaging? What is it that you're afraid of? And, you know, a mother would say, why would I bring my child with a fever to the Ebola treatment unit? As Peter pointed out, they're going to get it and it's more likely malaria. And they were right. The key for me was engaging the faith leaders. Just as in Ebola right now, we've got a lot of distrust of some of the policymakers and governments. And it's really when the faith leaders got engaged, listened to the community, which would be maybe a third take home from Ebola, and listen to the community. Those faith leaders are trusted leaders in their communities. And we as Christian health providers have a good connection with those faith leaders. And having them understand what COVID is all about and how to respond to it and how to care for their families and their congregations is really important. And that is something that we can add to this response that secular government and, you know, big UN agencies have a harder time doing.
Thank you. Go ahead, Peter.
Yes, thank you very much. And I think certainly that experience is a shared experience alongside. To add on, if you look at countries like Sierra Leone, Liberia, and DRC that have had the Ebola experience, we are finding an interesting level of resilience in this whole thing. We would have expected that they would have been overwhelmed with this whole crisis. However, they have sort of, they are doing so well in containment, all because one, the Ebola experience may have taught them that provided that community mobilization platforms, the capacity to mobilize, and the people appreciate their concept of public health emergency is real. It's a lived reality experience, so it is easier to tap into that experience. So community mobilization has been well, as well as risk communication and engagement for them to appreciate that indeed a public health pandemic of such nature could have potentially high mortality rates. They saw people dying in Ebola time, and then also it also facilitated something like compliance to all the COVID safety protocols. So it is a bit easier. And I mentioned about the role of our religious actors, very much so in all countries within HR network. One, because religious leaders are trusted, they have the social capital on questioning authority, they are able to neutralize the polarizing presence of the political actors in any place. And therefore, they're able to have the buy-in of the populace, visibility of all the measures are very high. And even when the partial lockdowns were announced by government, it took religious leaders to really to sort of give a public tacit endorsement of this before people could voluntarily comply, because government had no capacity to ensure 100% compliance. So in a nutshell, the past experiences with Ebola in most countries have had some unintended benefits somehow, or advantages in complying, COVID containment and mitigation measures all over. And I think that was a blessing in disguise. Ghana, that never had such an experience, is probably seeing more spikes, and we've had big challenges in getting compliance, population support and compliance in this whole thing. And I think that the Ebola experience is a lived one and of benefits. Over.
Great, thank you. I would only echo just briefly. In MSF, we're really I think taking the lessons learned about community engagement as well from Ebola, and going very quickly in this pandemic in a much more broad perspective, in almost every country in the world where we're working, really asking communities and leaders, including faith-based leaders, like what is it really the community needs here, and that's especially important in situations where we just don't have the resources to meet all of the needs. Okay, well, so Peter, you mentioned at the end there the situation in Ghana, and we had a question really specifically asking about COVID in Ghana. So this comes from Samuel Mwenda from Kenya, Dr. Samuel Mwenda, and really specific question, and I'll just read it here. Has Ghana considered home-based isolation care? how are you treating healthcare workers who have gotten infected in your health facilities? There was also a question there about routine services reduced. We touched on that a little bit already, but if you have something to say about that too, go ahead.
Yes, yeah. Thank you very much, David. And thank you very much, Dr. Mwenda. Yes, certainly. Right at the outset of this whole COVID response, we realized that we can never have enough COVID treatment centers or isolation centers, and therefore aware that COVID usually will have mild to moderate or severe levels and the rest. So Ghana has had to look at those with mild cases and the rest have had to home isolate. And within home isolation level, there are teams. The COVID response team will normally have to go to the environment to see whether the necessary physical distancing within the home environment was feasible. If not feasible, then of course, they were transferred to treatment centers or isolation centers. And for our healthcare workers in particular, who got infected, I would say virtually all of them have had to home quarantine or home isolated. And it has proven to be effective and cost effective in many ways. It is easier engaging people who are COVID literate, so to speak, who understand the rate, how COVID spread, how COVID can be contained. And therefore, for most of our health staff that were COVID positive and who were home quarantined or home isolated, all of them were treated or did mild symptoms and they emerged negative ultimately. And you asked about, the general impact on utilization of routine services. Yes, we are seeing, decreases in OPD and OPD levels. Service output data, is seeing a slump in all the cases. And you're only seeing people coming to the hospital in critical, conditions that are there. So certainly, COVID has had an adverse impact on utilization of routine services. So much as we look at COVID containment, demand creation and restoring confidence of our clients is also very necessary. Otherwise, post-COVID, there will be resort to herbal medicine and other dangerous practices that may even compromise our population health and even our herd immunity all over. So yes, to your question, home-based care, isolation, and the rest are part of the overall COVID response, plan in Ghana, and I believe elsewhere. Over.
Great, thank you. Maybe I'll ask you a question here, Anne, and this is really going to be a combination of two questions that came in, focusing on material supplies and stock. And in the MSF world, when we talk about emergency preparedness, EPREP, a lot of that comes down to stock. And I tell you, this is what I've been working on for the last 2 months, like for all of our projects around. And so questions are coming in about that because it's been a big focus. And, there's been a huge push globally to try to find enough PPE and to be able to equip our hospitals and facilities with the right supplies. And so one, I guess I would check in and see how your facilities are doing in that regard, which is an interesting first point of that question. But then the questions both from Glenn Erickson, from CMB, MMB, and then also from Morse Code Medical, we're really actually going to the next level and saying, is that too much of a focus? And how do we maybe turn attention back toward not necessarily PPE, but other regular needs of other supplies in the projects and facilities?
So first, I'll just say, and I hope to return to it, I think preparedness is much more than having the PPE. And we need to be ready for those, and there's going to be some benefits. On PPE itself, I think it has been a huge focus, and I'll say partly completely rightfully, because as Peter said earlier, the healthcare worker is essential to responding to COVID, to being able to care both for COVID and non-COVID patients. And so we do need to protect them. We do need them to continue to come to work and not be afraid that they aren't protected. I will say that for our organization, we usually get donated medicines and medical supplies and then distribute them to our partners around the world, more than 92 countries. And we get some PPE, but not very much. This is the first time we have done very large scale, millions of dollars worth of buying of PPE and spent a lot of time, like you probably have, trying to find the right place, the good quality, the tested and approved, and then trying to make the hard decisions about where does it go first. And basically, we've been triaging it to keep our own facilities running. So our a clinic in El Salvador, the one in the 10 clinics we have in Colombia, India, the US sites as well, and then trying to get PPE to the hot spots, to get enough PPE in there so that they can have the medical personnel to deal with surge. I will tell you, we get hundreds more requests than we can fill. And we know that nobody will ever be able to fulfill all of the needs for PPE. The one thing that I've been struggling with is it's not only an overwhelming volume of need, it's short term. The PPE can only be used so many times, and then you just need new stocks of it. So it's a something that really rotates, and I would like to see more long-lasting solutions. You know, it feels like we're just plugging a hole that we can't ever completely plug. So I've been looking at what are the longer term. When I think about our international programs where infection prevention control is difficult, and as was pointed out by our colleague from Morse Code Medical, these are very under-resourced places. We've been looking at our partners and going, how do we make sure they, maybe they don't have all the PPE they need, but do they have running water? Are there taps? Should we be doing infrastructure improvements that are long lasting that also contribute? And that hasn't been very much part of the conversation, but we learned this from Ebola, but also from cholera, that those kinds of things can be very important. Do you have isolation rooms that with extra protections in it? So I think that's one piece. I also very much agree with Glenn Erickson from CMMB that we haven't talked as much about essential medicines. And one of the things we did find early that is getting better now is our supply chain, routes were being compromised. Ports were being closed because they were quarantining and having a hard time getting things in. And that was starting to impact not just PPE, which you could usually get a waiver for, but the essential medicines, your antibiotics, your antihypertensive. And we've made a real emphasis also on trying to maintain a core supply of essential medicines to our partners across the world. If I could just for a moment go back to the preparedness is more than PPE. I talked a little bit about infrastructure, but a good example is our Philippines programs. It's also skills and practice skills. So we did preparedness training for our clinics and partners in the Philippines. One day we got a note that there was a fire in one of the clinics that had just had our preparedness training. And contrary to previous times, one of the guards, so we train not just the health personnel, but all of the personnel in the clinic, he smelled the smoke, he went in and he knew how to use the fire extinguisher. I would never have thought it, but actually they're kind of complicated if you don't actually know how to do it and aren't afraid to respond. You might not do it. This time, he found the fire extinguisher, he put it out in the electrical grid, and there was no long-term damage to the health facility. He immediately said, I could not have done this if we hadn't gone through our both preparedness plan, which is a paper thing, but had gone beyond that into what we do in boot camps, where you walk through the preparedness plan, you transfer skills in different areas so that they're actually really ready to respond. So I'd say preparedness is much more than that. There was one other associated question, and that is on the PPE and stockpiling. Wow, is that a hard one? I'd say and we do need to probably set aside some things. The way we deal with it is regularly rotating our stockpiles. So you should do it anyway to keep the medicines and supplies current, but that also allows you to bring it in to meet the current needs and then refill the stockpile on a regular basis. And having that does make a difference. We were able to respond very quickly in a couple places because we had a little stockpile close by. We keep emergency medicines and supplies in our warehouse in Connecticut, so we can very rapidly respond and get things out, because otherwise it would be weeks or months before we'd be able to get those things out to a place of great need. So I think we need to do it. The size and the turnover within it is one of the big challenges. So that's a lot, and I'll give it back to Peter and you.
Yeah, thank you very much.
Yes.
Yeah, Peter, why don't you roll with that a little bit? And I'd also be interested in your thoughts on how we make these decisions, you know, in terms of where a stockpile, for example, should go, how we deal with that ethically. Should this hospital have that, or should it be here? You're covering a network of a huge number of hospitals.
Yes, yeah, thank you very much. I think just to reinforce Anne's point and come back to your question, PPEs, by their very nature, are consumables, and you can never have enough consumable stockpiles the way it is and the rest. So the larger issue is about having sustainable supply chain system for the entire health sector, which is an ongoing question. When Ghana experienced, you know, sudden spikes in PPE, virtually all our PPEs were imported. I mean, face mask, virtually everything was imported, and so the sudden spike and all the borders were closed. So this led to a whole look at how do we build a bit of local capacity for the production of PPEs. So Ghana's experience showed that we switched into production of face masks, hand sanitizers, and basic things that could be, you know, I mean, that could be produced in-house. For us, of course, we are promoting WASH compliance in our healthcare facilities, basic IPC things, so that at least, I mean, it will ensure, you know, some level of containment. But then, not to say that outside support will not be needed. Certainly, international donations would remain indispensable. But then we have realized that they can only be complementary or supplementary to our local capacity, as we are seeing now. And so when it comes to the issue of PPEs, some of us believe strongly that we have to look at how do we ensure some basic level of local capacity to produce PPEs and the rest. And then you ask the ethical question of how do you distribute? Of course, we develop a criteria. Equitable allocation in this circumstance, very important. And it is always easier to look at the epicenters of COVID, and normally they're in the cities. And that is also about some neglect of the rural areas that may be asymptomatic areas, and they may even probably have a spike later on. So in our experience, whatever PPEs we had a delicate balancing act. Where are the epicenters? Which hospitals have reported, you know, have confirmed cases? That is one. Which facilities are in the peripheral area that have not had any confirmed case, and that we could provide PPEs to ensure that they prevent. Remember, most or 90% of all the confirmed cases ever passed through the lower centers, the lower levels, the clinics, the health centers. Before they were suspected, they became probable, and then they were confirmed over there. So we looked at equitable distribution of PPEs within the epicenters and also within the rural areas where capacity for even testing, the PCR machines are not there, the gene expert machines are not there, they don't have the cartridges and the rest. So they may be, you know, the unintended, you know, victims victims of our institutional neglect. So in distributing PPEs, number of active cases, important criterion, and yet the need also to prevent the transmission in areas without confirmed cases were also necessary. This is an ethical issue worth considering, but equity was very necessary, either in treatment or prevention of COVID cases in all levels. Over.
Yeah, thank you very much. Well, we're closing in on our time, and there's another question here we'll take. And coming back to the question of the idea that PPE is really, preparedness is really much more than just supplies, focusing on HR capacity. This question comes from Marcia Grand Ortega from CMMB, and it's a specific question about facilities relying on international doctors to fill HR needs. How do you adapt given the limited ability for international deployments? Suggesting in the question telehealth or virtual as an effective alternative. And then I would even broaden it a bit more and on top of that and say, how have your programs adapted to some of the really challenging HR challenges when there's an emergency like is happening now, whether it's international or national staff or other creative solutions. Peter, why don't you lead off with that one?
Yes, very well. I like the expression. COVID preparedness is much more than PPEs. Certainly, that is the case. And I think change of attitude, reorganizing the clinic workflows within the environment itself. Also part of really becoming less dependent on PPEs. But definitely attitude is very important, and attitude is really formed very well when the healthcare management or leadership is well informed and formed, and they are COVID COVID sensitive. Very important, so that they can make the necessary adjustments, which includes optimization of human resource levels. How do we even prepare our roster in such a way that staff could provide essential services and respond to both COVID and non-COVID cases very well? How do we virtualize some of the service? How do we, even when there is shutdown or lockdown, how do we provide some outreach services under some protection? Some of the services could be extended, could be reached out there. So we have had to have some level of internal reflection here within our system. And certainly, we issue some guidelines within this whole COVID era. One, how do we reorganize services and clinical workflows in such a way that so that the clinical environment becomes safer, both the client and the patient, the patient and also the healthcare worker become safer. How do we also optimize the services of each healthcare staff, either through outreach or virtual? And it has proven to be quite successful, though it is an emerging experience and a new era altogether. It is about making adjustments for necessary resilience. And these are some of the lessons COVID is telling us, that we may probably be sub-optimizing our staff. We may probably be not organizing our clinic workflow properly. How can we do things in a different way? The new normal, how do we normalize the new normal in such a way that we are able to fulfill our mandate of providing core essential services and also responding to COVID containment? These are raging questions that will continue to engage us before COVID finally says goodbye to us. Very interesting. Over.
Okay,
Go ahead.
take this into the first thing I would say around the HR issues, and from CMMB, I think about Haiti and how reliant it is on visiting doctors. So it's a really difficult situation. The first thing you have to do wherever you are is make sure the healthcare workers you have, however under-resourced you are, that they are protected, so that they are both stay healthy to be able to continue to provide services, but also that they are not afraid of getting COVID, so that they are unwilling to provide the services. So the first thing for dealing with HR surge is keep the people you got and make sure that they are going to be healthy and safe. it is really hard right now to, deploy teams. We normally do a lot of that and then support other teams, and many are not traveling right now. And so we've been doing, I think everybody is finding that they're having to learn telehealth in ways that we never anticipated we would do. And that I think it's here to stay. It's working better than anticipated. It cannot do everything. You still need some patients to be seen in person. In El Salvador, our patient count is about 20%, or at one point it was 20% of what we had been normally seeing. It's back up to about 40%. And what we're finding is, even in some of the places where we never thought we could do telehealth, enough people have smartphones that you can reach them. WhatsApp has actually been a fabulous platform in India, in Philippines, in Liberia, but you need to know who has it and how to contact your most critical patients. And I would say one of the first things then is you have to prioritize your patients. If you're going to see fewer of them, you need to know who's most at risk and know how to contact them. You can get that information in advance, which will make a huge difference. And we're also finding that, it seems hard, but where you have an electronic medical record, so that a provider who is distant from the patient can look at their record, it makes all the difference in the world. And we found that in our US sites, as well as in like our India site, where we do have an electronic medical record. So they were able to triage which patients most needed them. And then the provider, and many of our providers in India specifically, are older. So they really felt the risk of COVID. We're able to open up the patient's record, call them, have the conversation, and then refer them for the medicines and other things they needed. I think telehealth is here to stay, not as the singular way to go, but we can, and those of you who are working in sites that haven't yet been hit by COVID, now's the time to get ready to look at your health information technology, your WhatsApp. Is there another way? And get yourself ready to be able to do at least some portion of your patients through that modality. And that will also help with your need for healthcare workers, because you will be able to keep more of your healthcare workers engaged in patient care. So I think it's an exciting time, and we're learning, Peter talked about unintended blessings and consequences. We're finding some of those within COVID as well, in spite of, the great harm that it's causing. And I know we're really close to the end. I just want to say we have preparedness manuals, guidelines that are downloadable for anybody to use, that are specific for healthcare facilities. We have both all hazard ones and we have COVID specific ones. And just go to preparedness@americares.org and they'll connect you. And we also have mentoring sessions that can help a health facility walk through their preparedness plan and get it really actionable. And I wouldn't want to leave people without ability to access that resource. So thank you.
Thank you, Anne. Thank you for that last word as well. We do have to end, unfortunately, here very soon. Peter, do you have any last words of wisdom to share before we sign off?
Yes, thank you very much. Quickly, and the rest probably to follow up on Anne. Both CHAG and HR have some experiences on social behavioral change communications, risk communication, very important. But I believe that for the first time in most of our countries, COVID has brought in, even though challenges, but there are certain prospects, potentials, and pointers. Pointers for the entire health sector. For the first time, government, political leadership is appreciating the role of the health sector and how it influences everything. So we are looking at how do we leverage the COVID opportunities to influence policy change at the health sector, so that budgeting for health, equitable distribution for health resources for all actors will be necessary. And that is the experience we are getting in most African countries like Ghana, where the government has realized that frontline actors are not probably only political actors or leaders. The economy hinges very much on health. And therefore, we don't have to take our eyes off the ball. How do we seize the COVID momentum to effect changes, restructure our health system, advocacy, changes, policy changes and practices, so that COVID will rather be an opportunity, a blessing in disguise that could use to really, rehash and make our health system more resilient and responsive to humanitarian disasters which may come over. Thank you for the opportunity, and thank you so much for the experiences.
All right, well, thank you very much, both. Just as some closing words, I just wanted to say, I think the things that really I took out of this, lots and lots of, wise words about preparedness, really great questions. I think that a preparedness is a deliberate and it needs to be a very deliberate and reflective thing that you practice in your facilities. And that, can use established tools. It needs to rely on the people that you have. Especially in this time of COVID, we use preparedness both to respond to the emergency, but also to help to maintain our capacity and capability to continue ongoing services, so that the system really doesn't fall apart for the most vulnerable people who may be more affected by our routine morbidities like malaria or malnutrition, things like that. And then lastly, preparedness is yes, it's emergency stocks, and in this case PPE, but it's also so much more. It's really investing in your people, thinking about creative ways to be responding to the emergency that you're confronting, whether COVID or, as I said at the beginning, things that are much smaller for your own health facility. So with that, I want to say a couple things. One, thank you for all the questions. It was really great to have the input. Apologies to those we couldn't reach back to all the questions. We have recorded them, and we will be reaching out to you to try to provide some answers to your questions so that we can follow up on those in the next days. Also, thank you so much to both of our speakers, Ann Peterson and Peter Yeboah. Thank you both for your contribution. It was really a treat to have this conversation with you. Thank you to CCIH for this conference and for organizing. Please continue to post on the forum and on social media. And then the last thing, the last order of business before we close is a word of prayer. And Peter has graciously offered to give us a brief word of prayer before we close the session. Thank you.
Yeah, thank you very much. Our Heavenly Father, we are grateful for granting us the opportunity to be partakers of your grace, to enable us promote all measures and actions intended to mitigate and contain this whole COVID pandemic that is ravaging the world and affecting lives and livelihood. We pray that you grant us the necessary insight, the wisdom, the technical knowledge to enable us support our brothers and sisters afar and near, so that at the end of it all, healthcare workers will be protected, community would also be protected, and will be able to fulfill our mandate of being partakers of your healing ministry. Bless CCIH, bless the panelists, bless all faith-based organizations, political leadership, grant us the words for advocacy, give us the resources, give us the wisdom. At the end of the day, we'll always be grateful to you. We ask this prayer through our Lord Jesus Christ, your Son, who live and reign with you and the Holy Spirit, one God, forever and ever. Amen.
Amen. Thank you, Peter. And with that, we close the session. Thank you very much for your participation, and have a great day.
Amen.